Hello and welcome everybody to the Under 16 Cancer Patient Experience Survey Workshop 1. We've got a fantastic session planned for today and we're really very much looking forward to it. We've got a packed agenda today with a lot of different interesting talks that will be going on. I'm going to be handing over in just a moment to Jodie Moffat, who'll be giving an introduction and welcome to the overall event. We'll then be diving into the results, talking about both the quantitative and qualitative feedback that has been shared. We then have an excellent guest speaker who's going to be joining us. Yaser from Team Margot will be talking about being a parent of a child with a cancer diagnosis and going through treatment. We do have a comfort break that is planned for about 3:15. And then after the break, we'll be coming back to discuss understanding and interpreting the results, going through the different various reports and how people may wish to use them. We're then going to have a brief discussion about what's going to be happening in next week's session, which is the workshop session, before having a close and thank you. And there is going to be some time afterwards where if you want some individual one-to-one support to answer any of your questions, you will have that opportunity.
Hello everybody, Jodie Moffat. I'm Deputy Director for Policy and Strategy in the Cancer Programme at NHS England, and I use the pronouns she and her. It's great to see you all this afternoon and to have the opportunity to kick off this first workshop on the Under 16 CPES 2021 results. From my point of view, working in the NHS England Cancer Programme, I'm in no doubt that experience of care is extremely important. What care we receive, how we feel about that, really has a lasting impact, and it's absolutely crucial that we as national teams and as providers do what we can to ensure that every patient going through our services has the best care that they can. The Under 16 CPES survey really reflects the commitment that the NHS made in the long-term plan to hear from and actively seek the views and experiences of children under 16 who have had tumours or cancers and their parents and carers. And the first survey, which of course happened back for the 2020 cohort, was the world's first. There was nothing else in existence that was trying to get that national level look at how experience of care was being received. And so we were delighted to work with patients and children, their carers, NHS colleagues, other experts to develop that first survey. And then in this next iteration that we're drawing on for the 2021 survey, we've been able to continue to work with our stakeholders and crucially with patients and children and their carers to continue to iterate and develop and ensure that we're asking the questions that are going to get us the insights and areas for improvement that we need in order to make sure patients are well served. And so that has included a few different changes that you may have noticed. We sought to clarify the period of time over which patients were being asked to comment, and there have been some other tweaks as well. And I think that will be the story for CPES under 16 going forward, because we are at a fairly early days of the evolution of the survey. And whilst we absolutely had the adult survey to build on, we have of course noted that things are different, pathways are different, experience of care and what matters can be different for children under 16 and their parents and carers compared to adults. Just to note then on that, because of some of those changes, we're not making comparisons with previous surveys, so we're not comparing the 2020 and 2021 results. And we do have to exercise a bit of caution with the interpretation of some of the findings, because some of the response rate was a bit lower than we would have hoped for, perhaps, and some of the sample sizes, particularly for some questions, are smaller than perhaps ideal. So do exercise caution with that. But that said, that must absolutely not stop us from looking at these data and thinking about, what areas did it show us that we can celebrate as success, and what areas does it shine a spotlight on that need improving from that under 16 child point of view and their parents and carers. This time round, we continue to learn, as I say, and iterate, and there are a number of additional outputs that we're really pleased to be able to share with you. You will have seen, I hope, that there's the first time around for this survey, the easy read report, which I think is really important, particularly for the patients who are engaged in this and making the findings accessible to them as well. We have the interactive dashboard. There's also our 2 variable analysis, which allows you to have a look at results by a number of different variables to try and unpick where different demographics, for example, are intersecting. And there's also been a bit of a change in some of the suppression rules, which means that some of the findings that we may have had to hold back in the past because of small numbers, we're actually able to show now. So there's an absolute wealth of information there, and it's rich. And I and many of my national team colleagues really do see this feedback and these results as gifts that were given to us to help us to move forward, to look at where we can be improving things for patients, both now and of course into the future. And I do think that many people who take part in these surveys are not thinking about themselves necessarily, but about those that come next, and wanting to make sure that they have as good a time of it, a good as experience of care as it's possible to achieve. Okay, so of course, that whole point about acting on the results is a key part of this workshop today, and the future workshops and the work that you will do kind of outside of the Teams calls, very much on the ground, thinking about what the results are saying for your area. From my point of view as a national team, I am really delighted by the overall experience of care rating that we saw in the 2021 results, whereby we've got a rating of 9.01 from the parents and carers, and 77% of children responded that they felt that their experience had been very well looked after, which I think is absolutely amazing and a huge testament to the passion, the skill, the expertise of NHS staff up and down the country. But of course, against that backdrop of really positive results, there are absolutely areas that we need to be thinking about, areas of improvement, areas of variation. And as the national team, we have used the previous under 16 CPES results to inform what we are taking forward in our Cancer Improvement Collaborative. And I can see Claire Marshall on the call here, smiling and nodding occasionally. Thank you, Claire, to spur me on. So it's been really important to us to be able to think about how, as a national team, we can also take on board the findings from CPES, how we can weave them into the work that we're doing, and how we can take actions to improve things going forward. And as I say, the collaborative at the moment has been focusing on 4 areas identified by the previous under 16 survey. And excuse me while I just check what they are so I don't get it wrong. Communications and information, play, emotional support, and home comforts and facilities. And it is, again, another huge thank you and testament to the hard work and commitment of NHS teams that improvement work is continuing, even while there are very persistent and challenging operational things that need to be delivered alongside them, of course, as well. So thank you to everyone for that, because I honestly do think it makes a difference. We see that there's a legacy there, and it helps to identify and share good practice, which as a national team we can help with as well. We do also have the work that is being led by our Chief Nursing Officer, Ruth May, which follows on some similar themes, includes priorities around provision and quality of food, particularly in feeding parents, and also the provision and access to play specialists. And I believe that there will be an update on that work from Kate, who works on that nationally, in the next workshop. So I think that will be a really fascinating thing to hear about as well. Okay, so I'm going to draw that to a close for now. I just wanted to say thank you to actually, it's impossible to name everybody, and I do fear that I will miss someone out, but thank you to everybody who plays a part in the under 16 CPES survey. It is crucial. We do want to hear, we do want to know, and we do want to improve. I know that a lot of you were involved in the survey in securing the insights in the first place. So many of our colleagues at PICO and in our analytical teams around the different findings and the different outputs, and then crucially you now as well in terms of thinking about how we can take this forward. So thank you very much to you all for your ongoing commitment and energy in this area, and I look forward to a really excellent remainder of the workshop this afternoon.
Thank you so much, Jodie, for kicking us off there. And without further ado, we'll be handing straight over to Philippa. You're going to start looking at the results here.
Okay, so the Under 16s Cancer Patient Experience Survey measures children's experience of cancer and tumour care across England. It's run annually, and the survey's respondents are children who were under 16 at the time of their care, as well as their parents and carers who are invited to take part also. So the survey's been designed to monitor national progress on cancer care, provide information and drive local quality improvements, assist commissioners and providers of cancer care with decisions, and inform the work of relevant charities and stakeholder groups who are supporting children living with cancer. So the survey is run by PICA on behalf of NHS England, and it's overseen by a very active advisory group of expert stakeholders. All in all, we've got 13 principal treatment centres who are included in the survey. Looking at the eligibility, so patients with a confirmed cancer or tumour diagnosis who received inpatient or day case care from a principal treatment centre in 2021 and who were aged under 16 at the time of their discharge were eligible to complete the survey. A paper questionnaire with covering letter and then 2 reminders were posted out to parents, carers or children, with the option to complete the survey online or via telephone, which was also provided. We also have a free phone helpline and an email for respondents to opt out if they don't wish to participate, ask questions or complete the survey over the phone. We also offer a translation service as well. So the questions asked were about the child's cancer care during 2021, and there were 3 versions of the survey depending on the patient's age prior to field work. There's a survey for 0 to 7-year-olds, so this is completed on behalf of by parents on behalf of their children. Then we have an 8 to 11s questionnaire, which has separate sections for the child and the parent or carer to complete. And then a 12 to 15-year-old questionnaire, which again has separate sections for the child and young person and the parent to complete. So the survey was open to complete with fieldwork happening between April and June 2022. When we're going to look at the results today, figures have been rounded to the nearest whole percent and therefore may not always equal 100%. And also, please note that the question numbers relate to the numbering on the data tables, not the questions within the questionnaires themselves. In order to protect the identity of respondents, suppression rules have been applied to the data. So as Jodie touched on earlier, these have changed slightly, and where the total number of responses to a question is less than 11, data for the question has been suppressed, which is indicated by an asterisk. And double suppression, where the base size of any subgroups, for example, ethnic group or diagnostic group, is less than 11, the data for that subgroup and the next smallest subgroup is also suppressed. There's lots more information on suppression rules, and that can be found in the technical appendix, which is available on the Under 16 CPES website. So understanding the results, as Jodie touched upon earlier, Under 16 CPES is at a relatively early point in its evolution, and we continue to learn a lot about how it's working well and what we might need to change. So there are some differences between the 2021 and the 2020 surveys, and this has led to the analytical and insight recommendation that comparisons should not be made between the results. So in line with this, comparisons between 2021 and 2020 results are not included within the reports and the trends that we've shown. And this is because of a few factors. So feedback from cognitive interview testing with patients identified that clarification was needed on what time period patients should be reporting on. So changes were made to the 2021 questionnaire to accommodate this, but as this only affected this year's iteration, the 2020 and 2021 survey report on patients' experiences of care across potentially different or overlapping time periods. And additionally, there are differences in response rates across the 2 years. So this reduces statistical confidence in comparisons, and taken together makes it extremely difficult to disentangle this. So work will be undertaken to enhance comparability as much as possible in the future years. So looking at the overall response rate, out of 3,672 eligible patients and children, 960 responded to the survey, yielding a response rate of 26%. Here we just have a breakdown of the number of responses via survey mode, with the majority completing the paper questionnaire. And also looking at survey type. So survey type 0 to 7, which was completed by parents on behalf of children, yielded the highest response rate. Response rate is further broken down in the national report, and this is done by gender, ethnicity, and long-term condition. So subgroup comparisons, these allow us to explore the differences in how people experience cancer care. And the next few slides present responses to the questions asking about overall care in the survey by the subgroups of respondents. Some of the groups might be quite small, and so please take caution when looking at the results of these groups. And again, for any information on the number of responses for subgroups, if you want to visit the About Respondents page on the website, you can find a lot more detail there. So when we look at the results, the blue bars will always show the overall data, and the shades of pink present the data from each survey version or age group. When parents are asked overall how their child's cancer or tumour care was rated from 0, very poor, to 10, very good, 89% rated it as 8 or more out of 10. And this was similar across all the age groups. When we asked children about overall how well were you looked after during your cancer or tumour care by healthcare staff, 77% of children reported being looked after very well. This was higher for 12 to 15-year-olds compared to 8 to 11-year-olds. Looking at the gender of the patient, looking at these questions by gender, 91% of parents and carers of boys and 87% of parents of girls rated the overall care 8 or more out of 10. And then looking at ethnic group, so patients from a white ethnic background were far more likely to say that they were looked after very well compared to Asian, mixed or Black respondents. There were some differences in children's ratings to overall care by diagnostic group. For example, those with lymphomas and reticuloendothelial neoplasms, hope I've said that correctly, were more likely to say that they were looked after very well compared with some of the other diagnostic groups. Overall care by long-term condition, 89% of parents and carers rated their overall experience of child's cancer care of 8 or more out of 10. And it was very similar for parents of carers with children, with 88% with and 89% without another long-term condition. 77% of children reported being looked after very well for their cancer or tumour care by healthcare staff, and it was slightly higher for those without a long-term condition, 79%, compared to those with another condition, which was 73%. Overall care in children by deprivation. Children from the least deprived area, based on IMD quintile, were less likely to report being looked after very well compared to those from more deprived areas. However, data for the most deprived areas is suppressed. Looking at referral and diagnosis. So the data for each question is presented in the charts for all response options. So this includes non-applicable response options such as don't know and can't remember. And these response options are not included in the scored data, and therefore, as such, the percentages within the text accompanying the charts may not always match the percentages within the charts themselves. So looking at this, when asked before you were told that your child needed to go to hospital about their cancer or tumour, how many times did you see a GP about the health problem caused by this? 63% of parents and carers reported that their child saw a GP once or twice before they were referred to the hospital. And full data and scores, including how scores for each question are calculated, can be found in the national data tables, which are available on the Under 16s website. When asked, were you told about your child's cancer or tumour, was information given in a way that you can understand? Or were you told about your cancer or tumour, was information given to you in a way that you can understand? 73% of parents, carers and children reported that information at diagnosis was given in a way that they could definitely understand. And 75% of parents and carers reported that they were definitely able to find information about their child's diagnosis. Child's care and treatment. 57% of parents and carers felt that different hospital staff are definitely aware of their child's medical history, and 78% of parents and carers reported that they were given clear written information about their child's treatment. Just under half, so 45% of parents and carers said that their child was still receiving treatment, And of the remainder, 57% said that they definitely received enough ongoing support from hospital after their child's treatment has finished. 68% of parents and carers and children said that they're definitely involved in their child's or their cancer treatment as much as they would like to be. And looking at the impact of care and treatment on schooling and education, it was parents and carers of children aged 12 to 15 who were more likely to report that their child's schooling and education had been impacted by being either too unwell to attend school, having poor concentration levels due to ill health or worries, or by tiredness and fatigue caused by their cancer or tumour care than parents or carers of children aged 11 and under. Looking at care within the hospital, so specifically things for children to do, 43% of parents and carers and children felt that there was definitely enough things for the child to do in the hospital. This was lower for children aged 8 to 11 and 12 to 15 than parents and carers of children aged 0 to 7. And of those who needed it, 90% of parents and carers said that play specialist support was offered in the hospital for their child. So play specialists were mentioned in the free text responses, and Kirsty from Explain will elaborate on this with her feedback on those slides later on today. Only 34% of parents and carers felt that the hospital Wi-Fi always met the needs of them or their children. And when looking at hospital food, when we asked was there enough choice of food, 52% of parents and carers and children felt that there was definitely a choice of hospital food. So this slide shows some data relating to questions asked about the cancer care received at home or school. 97% of parents or carers and children felt that the nurses who came to their home or school were always friendly, and 87% of parents and carers and children reported that they always understand what nurses visiting their home or school are saying. 84% of parents and carers always have confidence and trust in the staff caring for their child, and this was slightly lower with 82% for parents and carers of those aged 8 to 11 compared with the 84% for both 0 to 7 and 12 to 15-year-olds. Looking at the bedside manner, so 76% of parents and carers felt that staff are always sensitive to the information that was being shared with them or when their child was in the room. And looking at communication, 72% of children reported that they could always understand what staff were saying. This was slightly higher for children aged 12 to 15 compared with those aged 8 to 11. 75% of children felt that staff always talked to them and not just their parent or carer. And comparisons by age group show that this was the highest for children aged 12 to 15 and lowest for children aged 8 to 11. So support for children aged 8 to 15. Children aged 12 to 15 were more likely to report hospital staff giving them information about how to chat to children other children with cancer or a tumour than those aged 8 to 11. And I'm actually going to hand over to Kirsty, who's joining us from Explain this afternoon, who will talk through the national qualitative results, which are now available on the technical reports page of the website as well.
Yes,
Thank you.
hi everyone. Thank you, Philippa. So my name is Kirsty and I'm from Explain, and we are also an independent research company that have been commissioned to undertake thematic analysis of the free text responses. So Philippa is going to drive the slides for me. I'm very grateful to that. Thank you very much, Philippa. So if you can just move on to the next slide, please. So these are the two questions that were asked at the end of the survey, and this is what forms the basis of the free text responses that we analysed. So to adults, parents and carers, they were asked, is there anything else you would like to tell us about your child's cancer or tumour care? Anything particularly good? Anything that could be improved? And similarly, children were asked, is there anything else you wanted to tell us about your cancer or tumour care? Anything good? Anything that could be better? So what we did was we took those responses and we performed a thematic analysis. And just very, very briefly, thematic analysis is essentially looking over a broad body of data, looking for similarities and differences and grouping them to help you understand experiences. So moving on to the next slide, please, Philippa. Thank you. These are the number of qualitative comments that we received by each age category. The number of people that actually answered the questions. I'm just reading some data from below me. So we had parents responding for the 0 to 7 questionnaire. We had 318 records of qualitative data. For the 8 to 11 questionnaire, we had 116 records of qualitative data. And for 12 to 15 questionnaire, we had 152 records of qualitative data. So overall, looking at the number of comments from parents, we had 548 comments, and from children, we had 163. So this is where looking at the background, the breakdown by age and the type of responses that we had. What I would like to touch on briefly, and if you look at the main report, you'll see that we had a varying number of responses by treatment centre. So what I think it can be a little bit of a pitfall when you're looking at qualitative data and trying to interpret it is to say, well, I don't know if that response came from my treatment centre, so I don't think it's particularly relevant to me, or that doesn't resonate with me. And what I would encourage you to do when we go through these slides and we look at the qualitative data is actually to kind of just think about it in general terms and use the themes and the issues that we are exploring here as prompts for thought, prompts for conversation, and prompts for further development. Thank you, Philippa. Next slide. Sorry, everyone. So that being said, 2 seconds. There are 8 groups of themes that came out from the thematic analysis. All are listed here. And they are shown in this way quite deliberately because the vast majority of responses can be grouped under an umbrella of positive experiences. And I'll explain all that in a minute, but I think it's very important at this point to remember that the positive experiences are the bed of this qualitative analysis, and everything should be viewed with that context. That being said, there are some areas that where participants, survey respondents, mentioned areas for improvement or some difficulties that they had. These are listed in the blue boxes on the right. So what I think it's important to do, as I think it was Jodie Moffat said at the very beginning, these are the gifts. So rather than view them as critique or rather than view them in a very negative light, these are the gifts that the survey respondents are giving you. They are showing you where we aren't doing as well as we perhaps could be and where we can make areas for improvement. So the rest of this presentation will involve me briefly touching on each one of these themes and explaining them a little bit more. Thank you. Next slide, please. So as I said, the vast majority of comments can be classed in an umbrella of positive experiences, and these very much resonate with the findings of the quantitative survey, which gave an overall satisfaction score of, I think it was 9.01 out of 10, and what we've then done is we've looked at these positive experiences and tried to categorize them down a little bit further. So overall, one of the things was that we found an overwhelming sense of just gratitude, and this was voiced in quite general terms. So people were just very, very grateful to the care that they'd had. So an exemplary quote for that is, "I could not be more grateful for the care my son has received and for his life-saving treatment. Both he and we have all been thoroughly supported and throughout the 3 years of his treatment, and I have trusted them totally. We are forever grateful." So people wanted to voice their gratitude and in a very general sense to their entire experiences of care. There were also people that wanted to point out positive experiences with nurses specifically, and that was quite an important relationship. And people were often reflecting on the way that nurses worked with them quite positively. And they talked about, for this quote example, "The nursing staff were also wonderful. We could not believe how hard they worked and how dedicated and compassionate they were." And I think it was quite important for respondents to single out nurses in a positive light. People also talked very favourably about place specialists, and place specialists come up in the qualitative data in 2 different ways. And so they first of all they talked about them in a very positive way. They found the interactions with place specialists to be incredibly useful. So, for example, the place specialist support at the hospital is invaluable. They provide consistency, familiar faces, and during multiple hospital visits, they bridge the gap between families and the medical staff during treatment times, providing additional support. And people also talked about, it was very important for people to talk about examples of good communication that they'd had between themselves and the people looking after them. And this again can resonate back to the quantitative data, because we had 76% of parents and carers felt that the staff were always sensitive when giving them information. And we had 82% of children reporting that staff always speak to them in a way that is suitable for them. So, for example, communication throughout the entire time and team, extending to the wonderful community nurses, has been amazing and consistent, which has helped so much. So, communication, when it works well, is really quite vital in people's overall experiences of their cancer care. Moving on to the next slide, please, Philippa. Thank you. So we also had, in terms of positive experiences, quite important to understand that when people talked about positive experiences with staff and positive thoughts about their staff, they voiced them in ways that they use quite common attributes that were really important to them. So they talked about being empathetic, about being friendly, kind, helpful, and professional. And those words, or synonyms of those words, really stood out to us when we were doing the analysis as ones that really were important to patients and their parents or carers. So a quote is, "The staff were absolutely amazing. They were supportive, empathetic, patient, and always positive despite the challenges faced by them and the children and the parents on the ward." And then, "We feel we've been very well looked after. All staff are friendly and understanding and helpful." And this again resonates quite strongly with the quantitative data. So there we had in 97% of parents and carers and the children feeling that nurses who came to their home or school were always friendly. 88% of parents and carers felt that they and their children were always treated with respect and dignity by staff. 84% of parents and carers always had confidence and trust in staff caring for their child, and 86% of children felt that staff were always very friendly. So moving on to the next slide, please, Philippa. Thank you. So I think once we have looked at what is, I think, very important to acknowledge is the vast majority of good work that is being done and is being very, very vocally acknowledged by respondents, sorry. It's time to move on to the gifts, the areas where we can look to develop. And the first one that kind of stood out was about negative experiences that patients, their parents and carers had, which were attributed to staff. So these were around, these can be grouped into a few themes. So one was around poor attitudes and behaviours of staff. And I think it's very, very important to point out that these were not frequently mentioned, but as a qualitative researcher, what does matter is that when they were mentioned, it was that the impact that they had was strong. So those kind of poor attitudes and behaviours of staff can be grouped into being unfriendly and a lacking of empathy, sorry. So not all nurses show empathy, and they need to understand from a parent's point of view. And there was also feelings that sometimes people could be insensitive in front of children. So I've had lots of infections and I felt really poorly, so I don't always like to eat, and I feel a bit worried when someone mentioned I should not be losing any more weight. I think they should have said it to my mum rather than to me. So people also talked about a sense of sometimes feeling unheard. And I think that this was quite important for people to feel that they had a voice in their care. So a quote being, "The doctors at the local hospital, not the oncologist, didn't listen, and they treated me as though I was stupid at times. This made our stays very hard, as not once did I treat them with anything but respect. However, I know my child and I am with her most of the time, and when antibiotics made her worse, I was ignored. She deteriorated and no one listened until an oncologist came in, by which time she was really very ill." So feeling unheard was linked to a sense sometimes as well. The feeling unheard was referenced specifically back to GPs and the experiences going through at the beginning of diagnosis. And importantly, I think in those instances, the respondent's perception was that this feeling unheard a fear may have led to delays in diagnosis. There was also a sense from a few respondents that there was a need for additional needs training, and this obviously was highlighted by the parents and carers of children with additional needs, and that they felt that these needs weren't always met by staff members, and some suggested that needed training on how to better support them. So, example, "My child has additional needs, and I find staff are definitely not aware or trained for children who have these types of problems." So if you could move on to the next slide, please, Philippa. So a further theme that we identified was around issues in access. And this was voiced in a few different ways. First of all, it was voiced in terms of the clinical nurse specialists, with a fear that sometimes those people felt that the the CNS was unresponsive. So we've had no contact from a specialist nurse throughout, and even when I asked questions via emails and text. And there was also worries in a few respondents about what happens when a CNS leaves or goes on sickness, and there just didn't seem to be any contingency plan in the care. So we've had no direct line of contact, instead having to go through our CNS to ask questions or chase appointments. But the person fulfilling this role changes almost monthly with no communication to say the last person's left or to introduce the new one. And again, I think it's important to note, that this was not always the case, but when these happened, it did have a large impact. And it does kind of resonate with the quantitative data as well, in which 59% of children reported always or mostly seeing the same member of staff for their treatment and care. And 76% of parents and children felt that the child was always able to get help from a hospital staff when they needed it. And 63% of parents and carers reported that they definitely had access to reliable help and support 7 days a week from the hospital. There was also issues that we found that were linked to patient and parent perception of understaffing. So people talked about how they felt that the nurses, for example, in this quote, were extremely busy. Parents have to give medicine themselves whilst in hospital, and long wait times for responses to buzzers. Now, obviously, we don't actually know, because of the limitation of survey data, what actually really happened on that ward or in those instances, because we can't unpick it anymore. But what we can say is that the perception of understaffing was causing issues for parents and carers and children. And there was also worries sometimes about access to a named consultant, with people feeling that they weren't able to see them frequently enough. So, for example, the primary consultant rarely came to see my son, which while we were inpatient, which we found inadequate. Our key worker was our middleman to our consultant and was almost impossible to reach. This lack of communication was below par for such a serious disease, and decisions to be made on behalf of our child. So I think that again shows how important it is for parents and carers and children to have this sense of a relationship, a working relationship with the clinicians responsible for their care. If you could move on to the next slide, please. So access issues was also emanated itself in terms of place specialists. So the second time that we talk about them in this presentation. Importantly, I think it's remember at the very beginning, we talked about how much people appreciated place specialists and their input. There was also a concern that place specialists and the availability of them just wasn't frequent enough. So particularly wanting to have more access at weekends. So for example, more play interaction should be offered to children by the play team, and they never have time and always seem to be short-staffed. And this does resonate in some ways with the quantitative data, in which 90% of parents and carers reported that the hospital offered place specialist support. So I think it just shows that how valued it is, and when it is absent or lacking or not frequent enough, what an impact it can have. There was also a general sense of feeling that they needed to be able to have care at weekends and at holidays, especially during wards. So, for example, there is little to no staff over weekends and holiday periods. Nothing regarding treatment happens. So if it's at the weekend, summer, Christmas, bank holiday, you have to wait until consultants return. There was also concern about the way that patients could access wards, and in particular, concerns that sometimes this had to be done via A&E, and particularly around having potentially highly immunocompromised children hanging around an A&E department for a very long period of time. So, for example, if my son spikes a temperature, he has to go to hospital for antibiotics and blood tests. This means going via A&E, where we often have to wait around 10 hours before being moved to a ward. It's tiring and stressful for us both. They're busy and know nothing about my son's medical history. Can we move on to the next slide, please? Another theme that emanated was around experience of delays, and again, the impact this happened. And delays were talked about in a few different ways across the analysis, and I'm going to just unpick them now. In terms of diagnosis, this was often talked about in terms of their GP and their relationship with their GP, and the way that the GP made the referral. And often people talked about difficulties in getting a GP appointment. Parents and carers sometimes felt that they were not being listened to by medical professionals, including the GPs. And again, that resonates with the quantitative data, in which 63% of parents and carers reported that their child saw a GP once or twice before they were referred to hospital. And 80% of parents and carers felt that their child was first seen by a hospital doctor as soon as they thought was necessary. So, for example, a good quote for this is, "We saw the GP at the start of an illness, diagnosed viral infection, child got worse, doctor's receptionist refused us an appointment, so we went to A&E." So there was also talk about the delays to particularly chemotherapy appointments once a child was in hospital. So this is when, once diagnosis has happened, once chemotherapy is being administered, you get to the hospital and you have to wait around quite a long time for the chemotherapy to actually be administered to you. So waiting time for the treatment to commence upon the arrival to the ward should be shorter. Each child at a time booked, so the treatment should commence without any delay, but this is often not the case. And quite often chemo was not ready on the time as well. So this issues around chemotherapy and delays to chemotherapy really did kind of stand out across the narratives about delays within the data set. There were also concerns about delays to procedures, and those procedures varied from blood tests through to waiting for beds and scans, and the impact that this had on people. So the treatment takes approximately 30 minutes to administer, but we were regularly waiting at least 6 to 7 hours. On one occasion, we were waiting 2.5 hours for a lumbar puncture in the waiting area. So there was often a sense of frustration from those levels of delays. There we go, thank you. So the experience of delays were also talked about in terms of receiving medication, and this was often attributed by respondents to delays in pharmacy. So to get any prescribed meds, we waited for 5 hours, even though I told the pharmacy what I needed at the beginning of the week, and we told them when we were leaving. And an important one was around delays to test results. And I think this stands out in some ways amongst all the narratives of experience of delays because of the impact that it had on people. And it was very clear that delays in test results was causing stress and worry to both parents and children. So I have one request to the team of the NHS to kindly provide the MRI follow-up results as soon as being on waiting lists of such illnesses like cancer is the worst. Next slide, please. There were also discussion about communication issues. And, as we said at the very beginning, when communication goes well, it really stands out to respondents and helps give them a very positive experience of their care. When communication falls down, and the opposite is true as well, in that it can quite negatively impact. So this emanated in a few different ways. One, quite strikingly, was around between hospital care. And this, again, resonates with the quantitative data because 54% of parents, carers and children reported that different hospitals providing cancer or tumour care always worked well together. And in the qualitative data, this manifested in that some parents and carers talked about communication between hospitals being lacking and that they themselves were left to share the information. And there was just an express need for more joined up and holistic care amongst different departments. So a good quote is that sometimes communication between shared hospitals broke down due to having different IT systems, and this caused delays in treatment and wasted journeys as appointments couldn't take place. There was also talk about communication issues within hospitals themselves. So, for example, in terms of parents providing updates, that was quite frequent. Well, it was quite frequently mentioned in terms of a frustration that the clinicians may not always know the child's history, and again, the parent had to kind of advocate for the child and almost act as the child's key worker. So staff don't communicate well, so we're forever telling them updates, chasing bloods and times. A lack of knowledge of patient history. So this goes back to the same issue. So lack of understanding of child's complex needs causes unnecessary distress, largely due to inconsistent communication and follow-up appointments. And there was an additional aspect about the introduction to the wards and how there was, I suppose, a failure to communicate everything that happened on a ward and how ward life was and the impact that that could have on people. So it's a very scary place on your first visit, and I had to attend alone with my son due to COVID. It would have been nice on the first visit to be greeted by a nurse and explain the unit, process, and provide some support. Next slide, please. So there were also communication issues around appointments, and this really kind of was around the a lack. So it wasn't that appointments were delayed. It was that the communication around them could sometimes be inconsistent and confusing, and that would have an impact on people. And this also resonates with the quantitative data, with 42% of parents and carers reporting that their child's care and treatment is definitely offered at a time suitable for them and their family. So, for example, many letters are sent out with conflicting time and dates, which is frustrating at times. And there was also sometimes a voiced need for a different way in communicating treatment. So people talked about wanting to understand more about the overall treatment plan, and not just a specific focus on what part of treatment was next, but understanding how that fit into the whole overall plan. His care falls short when it comes to understanding his overall treatment plan. So there was also a need to talk about delays in treatment, and communicate an active communication when those delays happened. So there's been occasions where my son has been waiting for hours for his treatment and there's been little or no communication. And there was also, importantly, a desire to have improved communication around decisions with treatment. So, for example, this quote, "Some decisions have been unclear and unexplained, and the endo doctors do contradict each other with their aftercare plans." So they just wanted to, I think there was a need to understand more about what was happening and why. Next slide, please. So this one relates to issues with food, which we have brought out as a separate theme this year because it was talked about a lot, and the way in which it was talked about varied. Had a very large impact often on children's and parents' experiences of care. So there were talks about the quality of the food provision being necessarily quite poor in taste or preparation. So the food was a disgrace. I had many challenges due to food not being edible, so it was raw or undercooked. But there was also concerns about the nutritional value of the food offered. So the better hospital food, as nutrition was lacking for a child with cancer. There was also concern about choice, and this again resonates with the quantitative data, with 52% of parents and carers of children saying that there definitely was a choice, and the qualitative data often reflected the lack of choice. So the menu was very repetitive, and some foods were offered every day. I think very importantly, there was a sense that there was a concern amongst parents and carers that the food offered during inpatient stays just didn't meet the needs of cancer patients. And that wasn't just necessarily around poor nutrition. It was also about the fact that cancer treatments can make people feel very unwell, as we all know, and that the food provision needed to reflect that and be more flexible. So, for example, the only thing my child struggled with throughout the treatment was the variety of different foods given on menus, and my daughter received chemotherapy. This left her with very little appetite, and the little choices of food never really suited our situation at the time. I feel like more variety should be given to suit oncology patients, more options to choose from. And there were also people talking about needing to be able to eat not at set ward meal times, but because of feeling very sick and nauseous, just being able to eat as and when. So being able to, the need to be able to get food at those times. Next slide, please. There was also talk from parents and carers about the financial impact of food provision. So it was identified that the lack of provision for parents alongside poor quality meant that they were often having to resource food from either local shops or takeaways, and that was having financial implications. And they reported often purchasing from takeaways, and that was just for them and for their children and the necessary expense. So when we're inpatient, us parents aren't allowed to have breakfast, lunch, or dinner. Only the children are fed. I think that's disgusting. As a family who are on a low income, we cannot afford to buy breakfast, lunch, and dinner when in hospital. So whoever is the inpatient with my child, either myself or her father, do not eat for that duration, which is sometimes weeks on end. There was also talk about the needs being unmet regarding food. So this emanated in terms of parents just simply not being offered food. And that particularly was difficult, especially for the parents of very young children who just felt that they were unable to leave their child to go and get food. And if somebody wasn't able to come and bring food to them, they often were just going without eating. So it was hard to leave my child to make food for myself. It would be better if parents were offered a meal as well as the child. There was also talk amongst parents of being willing to pay the hospital for food in order to overcome some of these issues. Even if payment is required, I would pay for food on the ward so that I can look after myself as well as my child. And there was also a failure sometimes within wards to have any provision to store or heat parents' foods. And something which would have made our main stay easier would have been better kitchen facilities for parents. And I think the main thing there is a reflection that parents and carers are just trying to really maintain or look after their own health so that they are in a position to be able to look after their children, and the difficulties that are incumbent with that when they are really struggling to find a way to eat. So next slide, please. I think there was also a very important note about unmet needs being related to aftercare. And this was voiced for both parents and carers and children to receive ongoing support after treatment had ended. And many felt that aftercare was absent or inadequate, and they discussed feeling alone at the end of treatment, finding it daunting to return to normal, like normal being inverted commas, without any support following the traumatic experiences of dealing with cancer. So this would highlight the need for aftercare improvement to those families that are having to navigate themselves back into society post-trauma. From first-hand experience, this is very hard, and the support you receive in hospital is quickly dropped following a remission or even child loss. There was also an unmet need in terms of the activities and entertainment provided whilst inpatients. So for younger children, and this was quite notably, it was age specific. So for younger children, this was voiced in terms of that they the inability to go out and get any pleasure, or the inability to play as and when they wanted. And for children aged 12 to 15, there was a sense that activities for the age were limited and that age appropriate activities were inadequately provided. And I suppose related to that was the fact that the Wi-Fi was often considered too poor, and this contributed to issues not just around entertainment but also trying to keep up with schoolwork for older children. And this also resonates with the data in the quantitative survey, with 43% of parents and carers feeling that there was definitely enough things for the child to do at the hospital. Next slide, please. So linking to that was this idea that needs vary by age, and that they older children in particular really struggled when they were on a ward with much younger children. So I was a teenager on a ward full of young and noisy infants with no privacy. There were beds available on the teenage ward, but because I wasn't yet 16, I was refused to move there, and subsequently my stay was pretty awful. And that child was aged 12 to 15. There was also voiced concerns about the inability to sleep in the hospital. And this again resonates with the quantitative data, with 32% of parents and carers reporting that the facilities for sleep were very good. And 28% of parents and carers and children reported that it was always quiet enough for them to sleep on the ward. So these discussions were emanated in terms of the facilities for sleep, the noise, and the noise from nurses sometimes was specifically raised. Next slide, please. And there was also a talk for mental health support. And this was not just at the end of diagnosis, but also during the treatment pathway. So the lack of mental health care, both at diagnosis and on an ongoing basis, has been a real negative, and at times has undermined the effect on the physical medical care, and that was a parent or carer. And then finally, whilst not raised frequently, in fact it was only a handful, but there were some comments raised about financial support, with parents reflecting on the financial impact that having a child with cancer has on them, and talking about needing financial support. So a cancer diagnosis has a serious financial impact on families. My husband had to retrain in a new area within his field so that he could work from home, taking a significant pay cut. We've had to rely on the generosity of actual strangers via crowdfunding services to survive. The financial impact on families needs to be addressed and helped in a real way where families are offered financial support. So there was a sense of a broad financial distress, but then there were also comments related very specifically to parking, because obviously if you're at hospital frequently on a long-term basis, it's expensive. So parking is a nightmare and very, very expensive. And then I'm just going to quickly, because I'm probably running out of time, touch on some of the wider issues that were mentioned in the report. And I think it can be tempting with these because they are clumped together under wider issues because they aren't directly related to cancer care. So it can be tempted to want to be almost dismissive of them, but I would encourage you to really think about them because they did have some marked impact on patients' experiences of their cancer care. So there were wider hospital issues related to sometimes talk about poor hygiene and cleanliness on wards, and a particular fear that that was going to have a negative impact on immunocompromised patients. There was also talking about needing to have ward updates, and particularly for children. So the wards and facilities are now 50 years old and in desperate need of updating. And then finally, I think it's important to note that because when the timing of this survey, the impact of COVID-19 did seem to have a lesser impact than on previous surveys, but it was mentioned occasionally, and it was mentioned in terms of visitors. So being only allowed a very limited number of visitors on an inpatient stay, and occasionally talking about facilities still being closed. So for example, play areas. So I think that brings me to a close.
Well, thank you both, Philippa and Kirsty. A lot of information that was given there with a lot of feedback about the results that are coming through. I do want to now welcome Yaser, who is going to be coming and talking about his experiences. Thank you so much for joining us today, Yaser.
Great. Hello, good afternoon, everyone. Hello. So Team Margot Foundation is the charity I represent, which is named after my daughter Margot, in her memory and to honour her legacy. And Claire Marshall asked me to speak today, and the four things that I'm really going to touch on are these four. The first two are sort of related: not recognising symptoms of cancer when Margot fell sick back in October 2013, and delays in obtaining a diagnosis and the issues that arose as a result, and then the difficulties receiving the most suitable treatment, and finally end on a positive, the things that were really good. So the reason I'm using this photograph is you can see this was when Margot was before diagnosis. This was June 2013, and I'm using this photograph because there's some bruises on her leg, which I didn't really notice, in all honesty, but my wife expressed increasing concern about because she felt I was holding Margot too roughly when I was carrying her around and doing this. She was our third child, so I was a little bit defensive at the time. This was August 2013, Margot's first birthday. And 2 days after this, she took a fall and cracked her head on the floor. And immediately there was a huge bump that appeared. Later, we learned that this was because she had a very low platelet count, most likely. And so this huge, whacking great bruise came onto her head. We were in America at the time. We went to an American hospital, saw a very elderly, experienced consultant. My wife had expressed concerns to me privately that Margot, maybe she was bruising, she was sweating, was there something going on here? And she flagged all these issues with that consultant. In fact, it wasn't the first time. We'd been to see the GP in the UK prior to this. Again, this is nothing to worry about. She's banged her head. We x-rayed her head. There was no cracked skull, thankfully, and we moved on. And this happened again when we got back to the UK. This was September 2013. Been to the GP. Margot was diagnosed with having a viral-induced wheeze. And this was the second visit to Kingston Hospital, but she had stayed the night this time. And the doctor was examining her as I came to collect her to bring her home. And I remember asking him very clearly, "Doctor, is Margot well?" And he said, "No, but she's well enough to go home." So that's what we did. We took her home. And so for Margot, poor thing, there were days when she just felt rotten. And that was because we hadn't diagnosed the fact that there was this nasty disease lurking and looming. She was redheaded, pale-skinned, 14 months old, couldn't really explain how she felt, banging into things as she started to learn to walk, and the cancer It was a blood cancer was lurking beneath and undetected. This was a week before she was diagnosed with leukemia. Insurgents in our bedroom on a Saturday morning, her and her big brothers. We didn't know she was unwell. We knew she was unwell, but we didn't know she was that unwell. And then on the 6th of October 2013, you tend to remember these dates, they get seared into the brain. It was a Sunday. She really didn't look well. I had a pediatrician, an anaesthetist friend of mine who suggested she go to see a pediatrician privately. If you're not getting the feedback that you need from GPs, go to see a private pediatrician. And so that following day, Margot was taken. She actually woke up that morning on the 7th of October and vomited at about 5 a.m. And we took her to see this pediatrician. This photograph was taken when Vicky had got back. My wife had got back from seeing the doctor, who had told her, go and pack a bag, pack an overnight bag. He had inspected Margot and had noticed a massing and a swelling around her abdomen. Her abdomen was slightly distended at the time. He suspected Wilms disease, a tumor on the kidneys. We later learned that your spleen gets enlarged when you have blood cancer. So off we went to Chelsea and Westminster Hospital, and this photograph was taken after 2 blood tests. What was incredible to us, and to me particularly, was until we got to Chelsea and Westminster Hospital, nobody had suggested a blood test. None of the GPs that we'd seen had even suggested she had a blood test, in spite of numerous visits to see doctors, multiple doctors, including family doctors who we met over that summer in America. All of my cousins are doctors, and we were very articulate. My wife particularly was very clear about the issues that were going on here, and could it be anything more sinister than something that will pass. So this photograph was taken after the doctors had left the room at Chelsea and Westminster Hospital and told us that Margot had leukemia. Now, I didn't know what leukemia was at the time. I knew it was life-threatening, but Margot was still sort of functioning reasonably normally. She's gurning at the camera. And they told us at that time that we would probably go to Great Ormond Street Hospital the following day. They wouldn't treat us at Chelsea and Westminster because she needed specialist care. Later that evening, actually it was in the early hours of the following morning, we were taken by ambulance to Great Ormond Street. And ridiculous as it sounds, straight into, I didn't appreciate, she presented in a what the doctors described as a perilous condition in their subsequent report. Early hours of the 7th of October, the 8th of October, with blood cancer, and this was in intensive care. We just arrived. What you don't see from this photograph is the number of doctors and nurses running around. It was clearly an emergency on arrival, and it was urgent, and she was in perilous condition. Margot was exhausted. We all were at this point. And what they prescribed first off was platelets. Her platelet count was non-existent, and without that, it wouldn't be possible to work on her. So platelets were ordered. I had no idea they were yellow, golden colored. And then subsequent to that, a red blood cell infusion. The doctor said, actually, what she needs is an exchange transfusion to get rid of her blood and replace it with the blood of a donor. And I wasn't even sure if they had enough blood. For that, Margot needed to be put into an induced coma, initially for the period of transfusion, but she later stayed in this induced coma for a little over a week in intensive care. We had to explain to her 2 older brothers as best we could what was going on. I think all of this could have been avoided had an earlier diagnosis been obtained with a blood test. This is Vicky feeding Margot milk through her nasogastric tube during that period of time. It was very touch and go. Mercifully, my daughter came out of that particular episode and survived to fight another day. So that was the issues that we experienced with the first 2 points there. The suitable treatment difficulties that Margot had were related to her mixed heritage. And long story long, the doctor said, look, she needs a bone marrow transplant. So here's the sciencey bit. Your bone marrow is your body's blood factory, and it produces these stem cells, which then change into the various different cells that your body needs to function normally. The downside of her mixed heritage was that if you're white Northern European, you have roughly a 70% chance of finding your perfect match. If you're Black, Asian, or from a minority ethnic background, those chances fall to about 20%. Those numbers have changed slightly. They're a little over 30% now. But if you're mixed heritage, well, there is no data. Your odds are worse still. And I'm Scottish, quarter Scottish, quarter Siamese, Syrian and Armenian as well. So that's just me. My wife is New Zealand and English heritage, and so our children are from all over the place. And that was a key issue for Margot to receive the most suitable treatment. Sorry, I'm galloping through this. A lot of what I'm saying as well is preempted by the fact that, you know, we are parents. And Margot was 14 months old at diagnosis. She wasn't able to speak and explain quite how she's feeling. So you have to bear in mind that what we're about to say, or what I'm about to tell you, which is feedback from my wife and I, really is our assessment of what had happened at the time. So things that were really good. Let's end on that. The small random acts of kindness. I mean, what we found was that someone had thought to offer us a room opposite Great Ormond Street Hospital at a sort of McDonald's lodge and book a bed for us. We didn't take that up at the time because we wanted to be close to the action at the time. But then they found a pull-out bed in just outside the pediatric intensive care unit for us to sleep on, just to get a couple of hours sleep. The human welcome on checking in, especially during the first 36 hours or so, A, at the hall, and B, at the ward. Whenever we joined a ward, having somebody welcome us on a ward was really very helpful. Warming up a ready meal in a microwave, you know, nothing to do with medical issues per se, but having an empathetic team was enormously reassuring. And we were never given false hope, but we're always told a straight story, always supportive and straight with us. We found it enormously helpful to have Oscar and Rufus, Margot's older brothers, receive some guidance. We got some guidance from the hospital team and the nurses on the fact that actually you need to bring them in. So 2 days after she was admitted to Great Ormond Street Hospital, we had our other children come in to see her. Actually, we were terrified about that. You know, how will that affect them? They turned up. She had a blanket over her. Oh gosh, are all these machines for Margot? Wow. And then the nurses talked them through what was going on. They thought she was asleep. How the lens of the child is different from the adults. Similarly, our wider family, it wasn't just us. We had my mother-in-law, we had other family and friends help throughout the time. And for them to be made to feel welcome was really reassuring. And then there were other things that I would never have thought of, like having a psychologist pop into the pediatric intensive care unit at Great Ormond Street Hospital. The chaplain, my wife isn't remotely religious, but nevertheless, having that person come, she wasn't overly bearing on the godly factor, but she was a human being at a time when we were in a hole, and it was really very, very very well received. Lastly, other things, I'm trying to stick to timetable, but sorry for galloping. Other things that we felt were well was, dare I say it, symptom care, also known as palliative care. I didn't use that phrase because I had an adverse reaction to it. I always considered it to be, you know, an admission of defeat. But Margot was extremely sick. Being able to deal with her at home, I received a phone call from Great Ormond Street at one point saying, look, this is no longer about the discussion we should have about her place of treatment. It's now about a place of death. And as parents, we had to consider that and how to deal with that. So having Margot at home with us was very reassuring. It enabled us to be together at a critical time. We were very lucky that Great Ormond Street Hospital had a palliative care unit at all. Many hospitals don't. It wasn't straightforward. For some reason, we ended up in an arm wrestle with Kingston Hospital about who pays. So we paid for the weekends or the weekdays, and the Kingston paid for the. But either way, we had treatment at home. Margot could stay at home. This is my son Oscar reading to her on the day she died, with my sister present, and it was very helpful for us as a family to have that time. I'm sorry I've galloped through this. I'm conscious acutely of timing and what I can and cannot say, but I'm very happy to answer questions either now or at a future time. Please just contact me as you wish.
Thank you, Yaser, for talking about your experiences here. It was really, really powerful to hear about what has been going on. Does anyone have any questions for Yaser?
Ask me anything you like.
Not a question, just thank you. Thank you for sharing your experiences, and thank you for having the strength and the fortitude. It's very, very, it's touched me. Thank you.
Yes, I completely agree. There's a lot of thanks being poured in here, and for talking about your experiences, but also talking about some of the really quite powerful things that were good about your experiences, noting a lot of little small random acts of kindness, and talking about the various stages and the experiences that you've had there. So thank you so much, Yaser.
It's a pleasure. I mean, there were references in the survey to play facilities. I mean, all of that came into play. It was very difficult to keep a toddler engaged for all waking hours. That was a struggle, particularly when Margot was in isolation. And someone was talking about post-trauma. She was clearly spooked after being in isolation, which is required for your bone marrow transplant to occur. For weeks you're in isolation, and Margot struggled with that as a young toddler coming out of there. But anyway, there's many issues here, and I hope that's given you a flavour, and it chimes with what your survey.
Thank you so much, Yaser. Really, really powerful.
My pleasure. You're welcome.
Hey, hi, welcome back, everybody. I'm now going to hand over to Amy Tallett, who's going to talk a little bit about understanding the reports that are available.
Thanks, Hanan. Welcome, everybody. So my job for the sort of next 15-20 minutes or so is to really support you in understanding and interpreting your data. So we'll be looking through the different outputs that are available. As Jodie mentioned at the start, there are a range of outputs available. There are some tools and outputs which are completely new for this year, so I'll spend a bit of time talking through those just to make sure people are comfortable with how to navigate them and know how to find them, importantly. Just to summarise in terms of what is available for the 2021 results. So I've sectioned this into two sections. So we've got national data. So we've got national quantitative report and an easy read version of that, which Philippa talked you through some of the key results earlier in this session. We've got the national qualitative report. Again, that's on our website, and Kirsty from Explain talked you through some of the findings after Philippa's talk earlier. We've got national data tables. You've got all of your number of % of responses to each question, to each response option available for all questions in the survey, and the ability to break down by different demographic subgroups as well with those. There are visual summaries. I will probably have time to show you those towards my end of towards the end of my talk, but if not, we'll have a look at those on the interactive dashboards that I'll definitely be talking through with you shortly. Two variable analysis tool. Again, I'll wait until I bring that up to talk you through it. And a technical appendix. And then the PTC, or Principal Treatment Centre level results. These are really what I'll focus on today when I talk through in the next 15 minutes or so. So Every PTC has a report, a standalone report for their PTC. There are data tables for PTCs, which again I'll bring up and talk you through how to navigate. We have the new interactive dashboard for 2021, and we have free text workbooks per PTC as well, so I'll talk you through those. I will head straight into the outputs and the demoing if there are no questions at this stage. So the first bit I'd like to point you in the direction of is the PTC reports, and I appreciate many of you have probably seen the reports associated with your own trust or PTC. On the website, on each slide, I'll give you the website link. Most of the outputs can be found on the technical reports page. So within that, you've got the national and the principal treatments centre results sections. As you can see, we've got a list of reports by PTC, so you literally click on the link and we'll download your report. Just important to mention at this stage that you'll notice that for the 3 jointly provided PTCs, their data is combined within reports. So Nottingham and Leicester combined, Great Ormond Street, UCLH combined, and frantically looking for the St George's Royal Marsden here, St George's Royal Marsden combined as well. We do have the ability to provide site-specific data, so rather than full PDF reports, sort of the data tables for you. So if that's something of interest, I know one joint PT has already requested that, but do let us know if you are a joint PTC and want to see data for your own trust only. Okay. So just to briefly summarise the sections in your PTC reports to sort of help you understand what you've got in there. So you've got background methods and how to interpret results section. A lot of that covers what Philippa covered this earlier today in terms of how people were invited to take part in the survey, how the survey was developed, and the approaches to things like analysis and suppression of data. Then you've got an about the respondent section, and this section shows what your overall response rate was for your PTC, number of responses, and then it breaks down the responses by things like survey mode, age group or survey version, and various other demographics, including gender, ethnic group, diagnostic group, etc. So you can sort of get to grips with the types of people at your PTC who have responded to the survey. The next sort of big section and the first sort of key section of the results in the PTC reports focus on overall care, and they look at subgroup comparison. So they break down the responses to the overall care questions in the survey. So by subgroup. So parents were asked overall how please rate your child's cancer or tumour on a scale of 0 to 10. And children were asked overall how well were you looked after for your cancer or tumour by healthcare staff. So you can see as what's shown on this slide, the example slide, is that you've got the data for the overall at your PTC, and then you've got data for girls and for boys. And they're available for survey type or age group, gender, ethnic group, deprivation, and diagnostic group. The next and probably biggest section of the report talks you through different aspects of your survey results by questionnaire section or topic. So what you've got here, and this is just an extract from the contents, you can see the different elements that are included in this section. So we've got a section about the diagnosis, the finding out about the cancer or tumour, care and treatment in hospital, care and treatment at home, healthcare staff, so that covers things like information, communication, interactions with healthcare staff, and support as well. And how these are structured is, generally speaking, each chart will give you 3 bars. It will give you the data in blue, which will always show the overall data, so everyone at your PTC. And then the shades of pink will show responses from the different age cohorts or survey versions. So as an example here, you can see the 0 to 7 survey respondents data is here, the 8 to 15 is the darker pink, and the overall is the blue bar. What's really helpful for context as well, and I do encourage you to look at, is the bit underneath, the context about who was asked the question. From this, you'll be able to understand if everyone in the survey was asked it, if it was only asked to parents, if it was only asked to children, if it was only asked to subgroups of people. For example, I think one of the questions earlier today was, how do we know the questions about diagnosis can be attributed to our PTC? So, you know, the questions of that nature will say this question was only asked to those who received a diagnosis at your PTC, as an example. Okay, so then following the sort of main results section, you've got a section called score tables. So what we've done, we've scored the data into sort of positively, so that the most positive aspect of care is scored as a single % by taking the sort of top or the most optimum response option to a particular question. So as an example, you've got here, you know, 83% of parents felt that staff definitely give them information in a way they can understand. So you've got the % for your PTC and the number of people who responded to that. And you can see that alongside the national score, so against all other PTCs that took part. Just to caveat again, I think importantly is the cautions, some of the cautions that Jodie mentioned when benchmarking results, you know, differences in things like type of care across PTCs, type of care and support provided by PTCs, differences in respondent profile between PTCs, can impact the comparability to the national score. So essentially things might look a little different at your PTC relative to nationally, which is why we need to interpret that with some caution. I'm just going to pause to check if there's any questions on the reports before I move on, and to give me a chance to have a gulp of water.
There's no questions on the chat at the moment, Amy.
Well, thanks, Philippa. Okay, so now I'm going to test my skills of changing from PowerPoint to internet browser, because I would like to talk you through the data tables on the website. Okay, can you all see the Under 16 Cancer Survey website? Philippa, can you see that?
Yes, that's come through. Thank you.
Amazing. Okay, so following me talking through the reports only give you a certain amount of information. They don't present everything in the survey, so there's a lot more information in the data table. So I really encourage you to go and look at data for all questions rather than just looking at what's in the report. The report is a great summary, but it doesn't give you everything. So what we've got here is the technical reports results page of the website. And if you're looking for data for your PTC or area in particular, what you want to select is the PTC data tables here. What this will give you is, bear with me, I apologise, let me try that again. Okay. It's an Excel document which you should be able to see. I appreciate this is going to look very small on screen, and due to the way it's formatted, it's going to be quite tricky for me to zoom in. So I'll keep this quite top level and brief. However, if anybody would like a more thorough talk through of the results at your organisation, feel free to reach out to us, because we can sort of have a one-on-one call with you to talk you through. But essentially what you'll find is a guidance page where you've got information about what's included and how to interpret the data in this document. The question list is a list of all questions in the survey and how they've been scored. So you can see which response options are taken through to the score in that particular question. The About the Respondents one is really useful, but it does relate to some of the information. Sorry, I have a cat intruder. It does relate to some of the information in your PTC reports in the About the Respondent section. So you can see who responded at your trust. So at your PTC, sorry. So for example, I am from Leeds as an example, and I want to look at the data for Leeds only, so I can see at my PTC the number of males that were in my sample of respondents is 37, and the number of females was 33. And again, you've got the different demographics there, so you can see the profile of your respondents. The scores page will give you the scores and the confidence intervals by scored survey question, again at a national and a PTC level. So again, you can use the drop down arrow here for PTC name, and you can select the PTC or PTCs that you would like to look at. I'm sorry, the cat has just gone and got on the back of my chair. I have very active cats. I'm just moving him. And you have, so you may want to pick your trust and look at how that compares to the national data, and you might be interested in particular questions, such as you know, if you know you're interested in certain question numbers, you can filter by those. You can see that actually you've got these two questions here at national and at my PTC level, and you can see what the different scores are and confidence intervals are for those questions. The subgroup data and the subgroup scores allow you to break your results down by subgroup. So if the data shows for every single question in the survey, you can see the full breakdown of response options. So as an example, let's just pick a question at random here. Are you and your child treated with respect and dignity by staff? You can see at your PTC, 89%, 88.5 said always, 11% said this sometimes happens, and no, under 1% responded with no. But what is quite neat with these tables is that you can then look at results by subgroup. So if you see these categories along the top, I will have to zoom out because we have frozen panes on here to ease navigation, but you can look at your breakdowns by gender of child, by ethnic group, by long-term condition, survey type or age group, deprivation, and diagnostic group. So it's really useful to really drill down a bit more into your data. And similarly, the subgroup scores does a very similar thing to the subgroup data, but on the level of scores, individual scores per question, rather than full data, every single response per question. And again, the ability to look at your subgroup data there. So that's a whistle-stop tour of the data tables.
Amy, we've got a question in the chat that I think would actually be really helpful to say out loud here. What is the confidence intervals on this?
The confidence intervals is the good degree of confidence you can have in the data. So of course, we've surveyed, it's a census survey, so we ask everybody who's eligible to take part in the survey, but not everybody replies. So what we can't do is have full confidence that your data is represented, what the response data is representative of everybody. So these, so let me take an example, because I think it would be good to give you a core examples here. So for a Great Ormond Street, 87% of respondents at Great Ormond Street said, well, of children that responded felt that staff were always friendly. We can't be fully confident that that's the case for everyone, for the whole population, but what we can do is be, sorry, I have lost my, what we can do is we can be between 77, we have 95% confidence that the true score will lie between 77 and 93 for that trust. The confidence intervals are quite wide here because the sample is quite small, and that's essentially a result of, you know, fortunately there aren't a huge population, a huge number of children with cancer in England that we survey in the first place. But is that a clear response, or do you understand that, or would you like me to elaborate a bit further? It is also included on the guidance tab as well. So there's information and in the technical appendix. So I'll bring up the technical appendix shortly so we can look through that as well. Is that okay?
Thank you. I think thanks, Amy.
Fabulous. Are there any other questions on the data, the tables, navigation, etc. before I go back to the slides?
Nothing else in the chat, and I don't think anyone's typing.
Fab. Okay. So, sorry, I'm just bringing up the going back to the website. So that covers off the data tables and the reports for PTCs. The next bit is quite an exciting bit because it's the interactive dashboard. So I think this place will be a really important place for PTCs to go and be able to interrogate their data a bit more, visualize it a bit more, pull off the types of charts and data for specific questions that they would like to see visually, plop into presentations, etc. So it covers the same information as on the data tables, but it's a bit more visual. So I'll give you a talk through that. So if you go to the results page and click on interactive dashboard, click here for the interactive dashboard. Again, we have a guidance page. The guidance page covers what is included and how to navigate this, but I'll give you a whistle-stop tour now. What you've got is these visual summaries, really nice visual summaries. So on the website, we have visual summaries showing images and highlights of the key national data. But what this allows you to do, so this is national, but what this allows you to do is if you click on PTC summary, you can pick your own PTC. So I'm just going to choose one at random here, Sheffield Children's here. And you say you might be really interested in seeing the overall results on care in hospital, and then you might be, I'm going to pick one which has got suppressed data here. Here we go. You might be really interested in seeing the data for were you given somewhere private to talk when your child was in hospital. You know, so for Sheffield Children's, 77% of parents and carers and children were always given somewhere private to talk. You've got a bit of context at the bottom here. You've got the number of people it was asked to at Sheffield Children's, how many people responded to this question. But what is very nice is you've got this download option, and that will allow you to download as an image or PDF. So actually you can navigate to any question that is of interest to you, and you can get a really neat summary. And you know, that could be used for sharing results on social media, in presentations with patients, etc. Sorry if I'm going too quickly. Hanan, Philippa, come in if there's any questions, but I'll just continue through. So national scores, again, we've got national and PTC scores, so I'll focus on the PTC ones. Again, you can filter by your own trust. So I'm going to pick on Oxford University Hospitals, and you can pick, you can view scores for questions by section of the questionnaire. So you might be really interested in looking at the questions relating to care that children receive when they're actually in hospital on a ward, or you might be particularly interested in just displaying the visual for a particular question, a single question, in which case you select from the drop down. And last but certainly not least, on the dashboards, we have the ability to break down by subgroup. So as I talked you through the data tables, the Excel document just now, and you've seen all of those columns by subgroup, this is essentially a visual way of showing that data. So this time, let's say we are Birmingham Women and Children's, and we really want a chart which shows answers to a question on empathy and understanding by ethnic group. So it will chart that for you. So on these ones, it will only allow you to do question by question rather than full sections. But you know, you can pick whichever you like here. You might wish to only look at the 0 to 7 group, in which case you can again use the filter to pick data for only one type of those. So at that point, I will pause again just to see if there are any questions or anybody would like me to recap anything on there before I move on.
Nothing in the chat. Thank you, Amy.
Thank you. Okay, so what I will do now is I will go back to the results page. Sorry, I'm looking down here to check I cover everything off. The other new output for 2021 is a 2-variable analysis tool. So this is again on the website and can be found here. What this unfortunately doesn't do is allow PTC level breakdown, and the reason for that is because as you'll probably see in a minute as I demo it at a national level, if we presented data at a PTC level, most of the data would be suppressed because you're cutting two demographic variables. You're cutting the data by 2 demographic variables. So it was only appropriate for us to produce it at a national level. but it still gives you a really good way to interrogate the data. So what it will allow you to do is for any question in the survey to look at results by 2 variables. And I think it's probably better if I just go straight to the demo and well, the real data, not the demo, and give you an example. I appreciate this might look very small on some of your screens, so I'll just talk you through what I'm doing in case you can't see it. So the drop down at the top allows you to select a section of the questionnaire. So I'm going to select healthcare staff. It will then allow you to select a specific question. So I'm going to select children can always reported that they could understand what staff are saying. And then it allows you to pick 2 subgroups. So I'll just keep what we've got on here, which is gender and survey type. The data that is shown as a result of that is essentially the scores for gender by survey type. So I can see that actually on a national level, male respondents in the 0 to 7 survey, male patients for the 0 to 7, so for the 8 to 11 survey had a score of 65. So 65% of 8 to 11-year-old children said that they always understood what staff are saying, relative to 81% for the 12 to 15 group. So actually I've just randomly selected this, but already this is quite an interesting finding because you've got quite a difference there between males who are 8 to 11 and males who are 12 to 15. And again, you've got a similar pattern if you look at the females here. You've got 63% of females aged 8 to 11 versus 79% of females aged 12 to 15. This tab is probably the most useful if you're all very visual and like looking at charts and like I do, like looking at bars and seeing differences there. However, if you do want to look at the full data that sits behind this, you have all of these tabs. So for example, we just looked at X14, question X14, gender by survey type. So if we go to gender by survey type, sorry, there's lots of numbers on this screen, and we go to X14, we can see the data that sits behind that chart that I just presented. So it's all there for you for every single question by every single variable pair. Again, I'm going to pause because I appreciate there's a lot to take in to see if there's any questions before I move on.
Hi, Amy. There is a question in the chat from Anne, but we're just putting together that data to respond through the chat there.
Oh, okay, fine. So I not directly something I can answer now, Hanan. I'll continue through then. Thank you. I was going to move on to the free text workbooks, but actually before I do, and while I am still on the website, just so as we saw in the dashboards, in the interactive dashboard just now, where we were looking at individual questions and images such as this for individual questions at national and PTC level. The results page of the website will also give you those visual summaries on a national level where you've got a few statistics in each box. So again, if you're looking to communicate some of the national level data, these are a really nice visual summary to summarise some of the key survey findings. The technical appendix, I know there was a few questions around confidence intervals and, you know, people might be wondering a bit more about the suppression information. So again, the main technical reports page of the results website, the technical appendix at the bottom, this will give you probably, hopefully, most of your answers that you need regarding the survey, the methodology, how we've scored the data, how we invited people to take part, etc. So that is all here for reference. Okay, so we've done data tables, we've done dashboard, we've done 2 variable. So we also, for each PTC, we have shared with you a free text workbook. Free text comments are available to you in these workbooks for all respondents at your PTC. And for joint PTCs, there's also a filter option to allow you to filter by site. So you should already be able to see in that data, the data for each trust or site within your PTC. So free text comments were analysed with a machine learning approach. So when Kirsty spoke about the approach to the national free text analysis earlier, that's a different approach. That was a sort of manual analysis approach, whereas for this piece, for the PTC level free text outputs, I'm going to talk you through briefly the process there. So we use a machine learning approach where computer algorithms are used to determine what the data shows. So semantic analysis assigns each comment into one or more subtopics, and then they're grouped together in broader topic areas. Just to give you a couple of cautions, a machine learning approach can't always take into account the context or the nuance of a particular response in the same way that a human analyst can when coding the data. So as a result, when you look through your free text reports, you might feel that some of your subtopics are not fully appropriate, or that some might not have been assigned to the correct topic. So that's just a forewarning that every single comment hasn't been looked at by a human, and for this reason we strongly encourage you to look through all of your free text comments. And I think for most, if not all PTCs, that's manageable within the number of free text comments you'll have within these workbooks. We encourage that you do this as well, because I think we might be able to pick up on positive or negative feelings or perceptions in the free text data, in your free text comments, that aren't necessarily evident from your quantitative data or from the grouping of the topics into charts. I'll talk you through this chart in a moment. So you might find that we've got mostly positive quantitative data on communication, but actually you've got one or two really negative comments on communication, which can really help you identify where there might be some room for improvement. So again, that's just to encourage you to look through, and hopefully some of the quotes that Kirsty presented earlier today really have demonstrated the richness of the free text data that's available. So moving to the free text reports, the main tab, other than a few worksheets with all of your data, is the main reporting tab, where you can you've got a list of all your main topics, and if you click on these topics, I can't bring up a real one because I can't share PTC level data because you have all of the actual comments underneath, but this is just a demo. That if you were particularly interested in comments about appointments, you would click on appointments. It would show the bar for appointments only, and then down here under the chart it would give you all of the individual comments that related to appointments. So it's a really useful way of navigating the free text data by topic. Do we have any questions on free text workbooks? I will take that silence as a no and continue.
Nothing is coming in the chat, Amy. Okay,
thanks, Hanan. So that's probably all I'll say around navigating your data and the outputs. If there are, I'll just pause to see if there's any general overarching questions on anything I've talked through in the last 15 minutes or so before I move on to the next couple of slides. No, okay. Okay, I've got a couple of slides on next steps for the survey programme as a whole. I won't be talking about the next workshop session in 2 weeks in detail, but I'll hand over to Hanan to do that shortly. So just to give everybody clarity on what's coming up with regards to the under 16 cancer programme of work, patient experience programme of work, a loose timeline. So we are currently cognitively testing the 2022 surveys. So the fieldwork will take place in spring next year. That means we need to test them thoroughly before then. We have made some amendments to the surveys as a result of a consultation exercise we had earlier this year as well. So it's important we test those changes. We do need, or we are struggling slightly to recruit for the cognitive testing. So I will bring up a slide in a moment which sort of showcases what we're looking for, but I guess this is just a shout out that if anybody is able to help disseminate the advert, which we'll share with you in a moment, to patients, to parents, to sort of encourage them to take part. There is a £60 incentive to take part as well, and it will just be sort of a remote interview interaction with us to go through the questionnaire, but I'll come on to that in a moment. The 1st of December, so in 2 weeks tomorrow, I think, it is the second workshop for this session, for this series of sessions. This is what Hanan will be talking to you about in a moment, but just a reminder, I guess, at this stage to sign up if you haven't already signed up to that, because it will be a follow-on from this session. So it's really important that you or somebody at your PTC is represented where possible. We have a national webinar on the 8th of December, so we're inviting anyone, the general public, anyone with an interest in the results to come along and take part in that session. It will be a summary of the national results, similar to what we presented earlier in this session, but there'll be a bit of time for a bit more interaction and discussion around the results as well. So feel free to sign up to that and let us know if you need the link. Sampling will start. We are starting to prepare for sampling for the next survey. So this is just to give everybody a heads up on key dates. We will circulate the slides, but essentially we will have a sampling webinar on the 11th of January, and sampling will start thereafter, with looking to go to field in March, April time. Okay, and my final slide before I hand back over to Hanan. So I just mentioned about cognitive testing. Who we're really looking for is anybody aged under 60. Well, any child aged between 8 and under 16 with a cancer diagnosis, and parents, carers of 0 to 7s. However, we do have quite a lot of parents carers, so I think we're, Caroline, correct me if I'm wrong, but we are quite covered there, and it's just the 8+ that we are really struggling to recruit. So yes, this is the advert. If you would like a PDF copy of the advert and you can help share it, please put your details in the chat and my colleague Caroline will follow up with you after this session with the advert. But the timeline is we're doing round 2 currently, so we're doing cognitive interviews this week, next week, then we'll pause and then we'll continue another final round after Christmas, so in January. So thank you in advance for any support you can give us there.
Thank you very much, Amy. Very good news there that the posters are already up in Southampton. That's very, very positive to see that.
Fabulous. Thank you.
So today we've had a conversation about what is being covered in the reports. We've talked a lot about the various feedback that is available. We've also had this feedback put into perspective by what Yaser has been talking about as well earlier in the session. I now want to briefly put it over to the audience, and I'd like to pose the question: what are we going to do with what are we going to be doing with our results? And if people can just pop into the chat who they're going to be sharing the results with, what their plans are for looking at this data and how it's going to be used. It'd be great to hear how this feedback is set to be used. As Amy said, there is a second session that will be running not next week, that is an absolute lie, 1st of December. So we've got 2 weeks, the countdown has started now to the December session. We've got quite a bit planned for that session, and just to give it an overview whilst people are popping things into the chat, we have an excellent presentation coming talking about the Sophie's Legacy project. NHS England is going to be talking about that and giving some detail about what has been going on there. We're also going to have a presentation joined by the Southwest ODN, talking a little bit about being part of the Cancer Improvement Collaborative and the work that has been going on, which is fantastic. But the majority of the session is going to be focused on us discussing the results together, talking about what we're feeling positive about, what we would be looking to improve, but also sharing ideas. That is the great thing about the group that is on this call. We're all having this experience across the country. So let's feedback and learn together. So that's why I kind of wanted to pose a few questions that I would like people to think about between these 2 weeks, between this session and the next one that is coming on the 1st of December. And those questions, if I can turn the slides, are really: what is it that we're proud of in our individual PTCs? What are we looking to improve? What would we like to learn from others? It's a great opportunity to ask questions of each other and see if there's any shared learning opportunities available. But also, what are we going to be doing with the feedback? I have pose that question within the chat right now, but it might be good to have that conversation as to how we're going to be working with this feedback. 960 people have given their views on this survey, so it's fantastic to see that we're doing something with everything that is available. Great to hear how widely this feedback is going to be shared. So that's very, very positive. I'm now going to hand back to Jodie here, who's going to be drawing this session to a close on behalf of NHS England. Thank you so much.
Thank you, Hanan. And thank you all. Just to echo what you said there, like I'm just smiling seeing all of those comments coming into the chat about the things that you say you're going to be doing as a result of this survey and the results, and all those people who so freely, gave their views. At what is a very difficult time for them. It's absolutely incumbent on us to act on those findings. And I'm just, delighted to see it all going. And we will absolutely be having the same conversations as a national team, thinking about next year's planning and what do we need to be thinking about. Just to say thank you all so much for taking part in the workshop today. Thank you. There is so much information that has been shared. Thank you to all of our colleagues who shared that info and all of those behind the scenes who have been analysing that information. There is a richness there. We've heard about the new different outputs and we could see that brought to life today. So thank you so much for that. I know many of you were touched both hearing Yaser's story and Margot's experience, and it's my second time of hearing Yaser, and it wasn't any easier the second time around. But of course, we're here because there are people like Yaser, like Margot, and families across the country, and we absolutely want to make sure that we're learning about both those things that are working well and we can be repeating and doing more of, and those things that we can clearly improve on. I guess I just, really look forward to the next workshop that's in a couple of weeks and to the responses that you'll have to the questions that Hanan has posed. I look forward to that. And just a huge thank you again for your huge input and commitment to making the under 16 survey a success. I noticed that we did hear a little bit about what comes next in terms of next year's survey, and that actually it won't be that long before we're back out to sampling. We've talked before about how the response rate this time around was a bit lower than perhaps we would have hoped. So if you've got ideas and thoughts about how we can pick that back up, if we need to be thinking about things slightly differently, or any other input that you think would be helpful on that, I'd be grateful for that as well. But main driver today is absolutely sharing on these findings that we do have and taking positive action. And again, thank you so much. And really looking forward to seeing what we could all be doing with this and improving things for patients in years and months to come.